When it comes to patients who are unconscious or have altered level of consciousness, your neuroassessment needs to be sharp. This is not a time to guess. You need to know what to check, what it means, and how it guides prognosis. First, let's walk through what we actually assess and why. We start with the basics: responsiveness and level of consciousness. Use the Glasgow Coma Scale. Check how the patient responds to verbal and painful stimuli. Do they open their eyes? Can they follow commands? Are their pupils equal and reactive? If they're obeying commands, that's a promising sign. If not, we dig deeper. Next, look at their respiratory pattern. It might not seem like a neuro thing at first, but it absolutely is. Cheyne-Stokes breathing, central hyperventilation, or ataxic breathing can all point to different areas of brainstem or metabolic involvement. Ataxic breathing, in particular, is a very ominous sign. Don't ignore it. Pupil exam is another critical piece. Are they equal? Do they react to light? Equal and reactive pupils in an unconscious patient suggest the problem may be metabolic or toxicologic, but unequal or non-reactive pupils can signal a structural lesion or increased intracranial pressure. Fixed and dilated pupils, especially if bilateral, can point to midbrain injury, and that's a serious red flag. Eye movements are next. If the eyes don't move at all, no tracking, no reflex movements, that suggests brainstem damage. You also want to check the corneal reflex. Lightly touching the cornea should cause a blink. This tests cranial nerves V and 7. If there's no blink, we're looking at severe dysfunction. Look at the face. Is there sagging on one side? Any signs of asymmetry or drooping may indicate cranial nerve damage or paralysis. Then check the swallowing reflex. Is the patient drooling, or do they swallow spontaneously? No swallow reflex increases the risk for aspiration and might mean cranial nerves X or 12 are involved. Check the neck. Is it stiff? That could suggest meningitis or subarachnoid hemorrhage. If there's no neck movement at all, we might be dealing with cervical spine injury or a very deep coma. Pain response tells you a lot, too. Apply nail bed pressure or joint pressure and watch how the patient responds. Purposeful withdrawal or movement across the midline is good. Random or no movement, that's a concern. Asymmetry can signal localized damage. Posturing tells you even more. Decorticate positioning suggests damage above the brainstem. Decerebrate, which involves full extension, means brainstem involvement and carries a worse prognosis. And if the patient is flaccid with no tone, that's the most severe response of all. Don't forget your reflexes. Tap on the biceps or patella to assess deep tendon reflexes. If they're absent, that could point to deep coma. If you see asymmetry, think focal neurologic issue. And be sure to check for pathologic reflexes like the Babinski. Toes fanning up in an adult is not normal. It usually means corticospinal tract damage. Once you've gathered all of that, you've got a good handle on where the patient is neurologically. Now it's time to shift into nursing interventions, what we do to support recovery or prevent decline. Let's start with fluids and nutrition. These patients aren't taking anything by mouth, and they're often on IV fluids. But here's the catch. In neuro patients, you must go slow. Rapid fluid administration can increase intracranial pressure, so always use IV pumps and monitor closely. Check skin turgor, assess mucous membranes, and keep a close eye on intake and output. Labs like electrolytes and BUN creatinine help confirm hydration status. If the patient isn't eating, which is common, enteral nutrition should be started within 48 hours. Short-term needs can be met with a nasogastric tube, but longer-term nutrition calls for a PEG or gastrostomy tube. Always confirm placement before feeding, and keep an eye on residual volumes and GI tolerance. Mouth care is not optional. It's essential. Check for dryness, crusting, inflammation, or ulcers. Poor oral hygiene can lead to complications like parotitis or mouth ulcers. Apply moisture to the lips, reposition the endotracheal tube daily if present, and use chlorhexidine oral rinse to reduce the risk of ventilator-associated pneumonia. Always elevate the head of the bed during oral care to prevent aspiration. Next, think about the skin and joints. Turn your patient every 2 hours without fail. This helps prevent pressure injuries and keeps circulation going. Use foam boots to avoid foot drop, splints to maintain limb alignment, and trochanter rolls to support the hips. Passive range of motion exercises help prevent stiffness and contractures, but remember, never drag a patient across the bed. Use a lift sheet to protect both the patient and your own back. Specialty mattresses like low air loss beds or fluidized therapy beds can help, especially in high-risk patients. Corneal protection is often overlooked, but it's critical. If the patient has an absent blink reflex or their eyes stay open, you need to step in. Use moistened cotton balls with sterile saline to gently cleanse the eyes. Apply artificial tears or methylcellulose drops to keep the corneas lubricated. Avoid placing cold compresses or eye patches directly on the eyes. Use protective eye shields instead to prevent trauma. Finally, let's talk temperature. Unconscious patients can develop fevers for many reasons: infection, hypothalamic damage, drug reactions, or dehydration. Your goal is to keep them at normothermia, around 98.6 degrees Fahrenheit. If there's a persistent fever with no clear infection source, that could indicate brainstem damage and often means poor prognosis. To manage fever, remove excess bedding, keep the room cool, and use antipyretics like acetaminophen or ibuprofen. Cool sponge baths or cooling blankets may also be ordered. And remember this: do not take oral temperatures in an unconscious patient. Use rectal, tympanic, or core temperature monitors instead. Safety first, always. Let's bring it all home by talking about what keeps our patients safe, clean, and gently nudged back toward recovery, even when they can't tell us what they need. These are the things that matter just as much as the neuro exam or IV drip. This is where nursing really shines. First, a few non-negotiables. Always elevate the head of the bed to 30 degrees, unless there's a medical reason not to. That simple move can lower the risk of aspiration dramatically. It keeps secretions draining properly and helps protect the airway, especially in patients who can't swallow or cough effectively. And even if your patient isn't moving, blinking, or reacting to much of anything, I want you to talk to them like they can hear every word. Because they just might. There are stories upon stories of patients remembering what was said to them while they were unconscious. So skip the pity party and sarcasm and keep it kind, calm, and clear. Dignity matters. Now let's talk about restraints. Avoid them if you possibly can. Agitation can often be managed with voice, music, or even a hand on the shoulder. But if a restraint is truly necessary for safety, you need a written provider order, and you better monitor that patient closely, especially during cooling therapy. Shivering during active cooling can actually increase intracranial pressure, so watch for it and intervene early. Cooling blankets are helpful, but only if used properly. And now for the part of nursing nobody brags about on Instagram: bowel and bladder care. Let's start with the bladder. A full bladder in an unconscious patient is not just uncomfortable, it can lead to urinary retention, overflow incontinence, skin breakdown, and infection. So check it regularly. Palpate or use a bladder scanner. If they're retaining urine, intermittent catheterization is the preferred route. It reduces infection risk. But if they're unstable or you need to monitor every drop, an indwelling Foley may be necessary for a while. Just don't leave it in longer than it needs to be. If you're using a Foley, keep an eye out for fever, cloudy urine, or a foul smell, all classic signs of a UTI. Check the skin around the catheter site too. Redness or drainage? You've got a problem. Once your patient is stable, get that catheter out. Then scan the bladder to make sure they're emptying properly and start bladder training if needed. That could mean scheduled toileting, using a condom catheter for male patients, or trying female incontinence devices for the ladies. And if accidents happen, clean the skin immediately. Use barrier creams and no rinse cleansers. Incontinence-associated dermatitis is no joke. It sets the stage for pressure injuries faster than you'd think. Stay ahead of it with a solid skincare routine. Now onto the bowels. Monitor for bowel sounds in all 4 quadrants. If you haven't heard anything in a while, or the belly looks distended, measure that abdominal girth and take note. Watch stool patterns too. How often, how much, and what consistency. A sudden bout of diarrhea might not be what it seems. Tube feeds, antibiotics, or infections can cause true diarrhea, but sometimes what looks like diarrhea is actually overflow around a fecal impaction. That's a totally different ballgame. If your patient's not moving their bowels regularly, take action. Stool softeners, suppositories, stimulant laxatives, or even enemas may be needed. Fecal collection devices can help in cases of severe incontinence. And don't be afraid to do a rectal exam if nothing's moving. We've all been there. But nursing isn't just about cleaning and scanning. It's about healing. So let's talk about how we help these patients reconnect with their world, even when they're trapped inside it. Sensory stimulation is key. We don't just want them surviving. We want them waking up. That means light during the day and darkness at night to preserve normal sleep-wake patterns. Photos of loved ones, soft music, familiar scents like a favorite lotion or cologne, these little touches matter. Use gentle touch during care. Offer range of motion. Change positions. Even if they can't respond, their brain might still be logging those inputs. Family can help here too. Let them talk to the patient. Hold their hand, read to them. Encourage them to bring in personal items or recordings of home sounds. Avoid any talk that sounds hopeless or negative. This is a sacred space. As the patient begins to emerge from a coma, things can get tricky. Agitation is common. They might pull at lines, thrash around, or look scared and confused. Before reaching for medication or restraints, try the basics. Calm voice, soothing music, dim lights. Reorient them regularly. Tell them where they are, what day it is, what happened. Repeat it every 8 hours or more. It helps rebuild the sense of self. And above all, be their lifeline until they find their way back. You are the bridge between silence and speech, between stillness and movement, between survival and recovery. As your patient starts waking up, slowly, foggily, maybe even angrily, it can be a hopeful but challenging stage. Emerging from a coma doesn't look like the movies. There's no dramatic gasp and sudden memory of everyone's name. Sometimes it's confusion, staring, or moaning before anything makes sense. And while that can signal neural recovery, you've got to manage the environment with care. Keep stimulation low. Quiet the room. No overlapping conversations, one voice at a time. Give them time to respond, and let them rest. Recovery isn't a sprint, it's more like slow-motion rehab. Now, when it comes to memory, these patients may have gaps the size of Texas. They'll need help filling in the blanks. Encourage families to bring photo albums, play home videos, or record stories from life events. It's not just for comfort, it actually helps with emotional reintegration. Some folks swear by structured neurostimulation programs. Others say they're overrated. Either way, consistency matters. Let's not forget the other half of this story, the family. Families living through this kind of trauma don't just sit quietly in the waiting room. They ride a roller coaster of emotions: shock, panic, denial, grief, anger, helplessness. You'll see it all. Some are calm, some are loud, some try to take over your job. They're scared because the person they love might never be the same. And our job, it's not just to care for the patient, it's to shepherd the family too. Offer clear, honest updates. Be gentle, but don't sugarcoat. Invite them to participate in safe ways. Holding a hand, helping with lotion, reading a favorite book aloud. Guide them with empathy and facts. And when the grief is too heavy, help them connect with chaplaincy, social work, rehab programs, or grief counselors. No one should walk through this part alone. Now, sometimes the hardest conversations are the ones about brain death. You may be at the bedside when the words "no brain activity" are said out loud for the first time. It's gutting. Brain death is not a coma. It's not a vegetative state. It's the irreversible loss of all brain and brainstem function. But the body can still look warm. The chest may still rise and fall with the ventilator. The heart may still beat with vasopressors. That can be confusing and painful for families. This is where nursing presence matters most. Use compassionate, consistent language. Reinforce what the provider team shares. And if it's time to discuss organ donation or end-of-life options, bring in the right support and let the family process at their own pace. Of course, while all this is happening, you're still doing the daily grind of keeping that patient alive and complication-free. That means staying vigilant for all the usual suspects. Let's talk complications. Respiratory-wise, you're watching for signs of aspiration, pneumonia, and flat-out respiratory failure. Monitor vitals, SpO2, ABGs, and white counts. Suction if needed. Do chest PT. Keep that mouth clean like it's your own. And if there's even a whisper of infection, get cultures and start antibiotics fast. Skin-wise, you better be doing more than just flipping a pillow. Check every bony prominence, especially the sacrum, heels, and elbows. Risk factors: immobility, incontinence, poor nutrition. Your go-to interventions: turn every 2 hours, keep skin clean and dry, Use barrier creams and apply specialty support surfaces like waffle boots or heel protectors. VTE prevention is non-negotiable. These patients are sitting ducks for DVTs and PEs. You're giving subcutaneous heparin or LMWH, using SCDs or compression stockings, and doing passive range of motion like clockwork. And if a patient suddenly complains of calf pain, swelling, or chest pain, don't brush it off. Act fast. Contractures are sneaky. They creep in when nobody's paying attention. That's why ROM exercises twice a day matter. Splints can help preserve hand function and foot position. The goal? Prevent spasticity and keep whatever mobility they might regain. So how do you know you're winning? Well, here's your end-of-shift gold star checklist, those sweet expected outcomes we all want to chart. 1, breathing, steady. Oxygenation intact, ABGs on point. 2, no injuries, no falls, no skin tears, no new drama. 3, hydration and nutrition, labs stable, INO balanced. 4, oral health, moist mucosa, no ulcers or grossness. 5, skin intact, no pressure injuries. 6, corneal integrity, protected, no abrasions or dryness. 7, temperature, normothermic without shivering. 8, urinary health, no signs of retention or infection. 9, bowel health, no impaction, diarrhea or constipation. 10, sensory function, patient shows appropriate responses. 11, family coping, they're expressing concerns, asking questions, and feeling part of the care plan. 12, no complications like pneumonia, pressure ulcers, or DVT. When all of that's in place, you didn't just keep someone alive. You helped protect their dignity, their safety, and their family's peace of mind. You became the reflexes they didn't have. You filled in the gaps until they could start to wake up.